Welcome, everyone, and thank you for attending today's webinar on guidance for avoiding fraud, waste, and abuse, a presentation for New Jersey pharmacy providers. I'm Melanie Donnelly, and I'm an administrative analyst in the New Jersey Medicaid Fraud Division. Today's webinar is specifically tailored for pharmacy providers who provide services to New Jersey family care members. Today's presentation will be recorded, and following it, the slides you're about to see will be posted on the Office of the State Comptroller's website and also shared by email. So we're presenting today in partnership with a number of New Jersey state agencies and key stakeholders of the New Jersey Family Care Program. And that includes the agency that I'm a part of, which is the Office of the State Comptroller Medicaid Fraud Division, the Department of Human Services Division of Medical Assistance and Health Services, or DMAS, the New Jersey Family Care Managed Care Organizations, or MCOs, the Division of Consumer Affairs, DCA, and the Office of the Insurance Fraud Prosecutor Medicaid Fraud Control Unit, or MFCU. And before we really start today, we want to thank all of those of you who are enrolled in the New Jersey Family Care Program and who provide services to these members. The work that you do is so incredibly important, and we just want to express our gratitude for that. A bit of housekeeping. This presentation is intended for general educational purposes only, and it does not replace your responsibility to seek professional guidance, observe laws and regulations that pertain to your practice as a Medicaid provider, and exercise professional judgment. And the goals for today are to help you better understand the Medicaid program's regulatory oversight structure and compliance requirements, along with potential red flag areas for pharmacy providers. We're also going to touch on fraud, waste, and abuse obligations of providers and consequences for non-compliance. And we realize that some of you may have come into this with questions, or the content that you're about to see may prompt questions for you. If you do have questions, please enter them into the Q&A. The Q&A is an area that we will be able to access following the training and be able to coordinate responses to your questions and get back to you. Anything that we can answer in the moment on the Q&A or chat, we will do that, but I suspect that many of these will require thoughtful responses, and we will take those back and be back in touch following the presentation. So now that the housekeeping items are out of the way, we'll get started on the real material. So we'll start by briefly addressing what is Medicaid. Medicaid is a jointly funded federal and state program that provides funding for medical costs and specialized services for eligible individuals. And participation in the Medicaid program is voluntary. But if you do want to participate, you must know, accept, and abide by the rules and regulations. And if you want to continue your participation, it does require compliance with regulatory requirements. Throughout this presentation, you might hear the words Medicaid and New Jersey Family Care used interchangeably. That's because New Jersey Family Care is the name of the Medicaid program here in New Jersey. And New Jersey Family Care encompasses Medicaid, the Children's Health Insurance Program, or CHIP, Medicaid expansion, and Medicaid services that are provided through the state as well as through the 5 managed care organizations, or MCOs. And this slide is just to orient you on the different state agencies here in New Jersey involved in overseeing Medicaid pharmacy providers. So starting on the left, you'll see the Department of Law and Public Safety, and that houses both the Medicaid Fraud Control Unit, which is the criminal arm of Medicaid oversight, along with the Division of Consumer Affairs licensing boards, which includes the Board of Pharmacy. And that also includes the Enforcement Bureau. And we'll talk about those areas a bit later in the presentation. And then next towards the center of the slide is the Department of Human Services, which encompasses the Division of Medical Assistance and Health Services, DMAS. And DMAS is the entity that holds the contract with the Medicaid managed care organizations. And those are the entities that may be more familiar to you. And then next is the Office of the State Comptroller. And this is an independent state agency, maybe not as familiar to you, but within this is the Medicaid Fraud Division. And that is the civil arm of Medicaid oversight. And again, we'll touch on the Medicaid Fraud Division a bit later in the presentation. And then last but not least is the Department of Health, which contains facility licensing, such as hospital licensing. And now I'm going to turn it over to my colleague, Kia O'Neill, who's a supervising investigator here at the Office of the State Comptroller Medicaid Fraud Division. She's going to touch on some guiding regulations, statutes, and newsletters for the New Jersey Board of Pharmacy.
Thank you, Melanie. So the New Jersey Board of Pharmacy guiding regulations, statutes, and newsletters. As a New Jersey Medicaid enrolled provider, it is your responsibility to observe all state and federal regulations and statutes regarding pharmacy providers. There are many different entities that regulate the pharmacy space, which you see on the screen. Today, we will be focusing primarily on the Board of Pharmacy and the state Medicaid agency components. The purpose of the New Jersey Board of Pharmacy is to promote, preserve, and protect the public health, safety, and welfare by and through the effective control and regulation of the practice of pharmacy. The Board of Pharmacy is also responsible for the licensure of pharmacists and the permitting, control, and regulation of all pharmacy practice sites in this state that engage in the practice of pharmacy. The board protects the public by making sure that every pharmacist has met all of the necessary requirements for licensure, investigating and disciplining any pharmacist who has not complied with the Board of Pharmacy's laws, enforcing the requirement that every pharmacist continue their professional education and training to keep current with the evolving world of pharmacy, requiring that all pharmacies be registered by the state and renew their permits annually, and ensuring that patients receive the prescribed medication. Related regulations and statutes include the pharmacy statutes, the State Board of Pharmacy, Controlled Dangerous Substances, Uniform Prescription Blanks and Prescription Monitoring Program regulations, the Uniform Enforcement Act, the Licensee Duty to Cooperate. You can find all of these Board of Pharmacy regulations and statutes on the Board of Pharmacy webpage under the Laws and Regulations tab. You can find the Board of Pharmacy newsletters by accessing the New Jersey Consumer Affairs website at the listed address and then select Useful Links. Board of Pharmacy alerts can be accessed in two ways: under the home page and under the alerts page. I am now turning it over to Linda Grajeda, who will touch on DMAS guiding regulations and newsletters.
Thank you. Hello, everyone. I'm Linda Grajeda, Chief of Managed Care Operations at the Division of Medical Assistance and Health Services, which we call DMAS. Next slide. As stated, DMAS, or the Division of Medical Assistance and Health Services, is part of the New Jersey Department of Human Services, and we administer the state and federally funded Medicaid program for certain groups of low to moderate income people. What you see here is a screenshot of the Medicaid website at the address you see listed there. Here you can find DMAS regulations. If you click, as the arrow indicates to the left, on the state and federal websites, and then you can bring up the regulations. Specific regulations related to pharmacy are listed there, the Pharmaceutical Services Manual, and it applies to fee-for-service pharmacy claims. In addition to the regulations, it's important to be aware of DMOS newsletters. Medicaid newsletters are used to introduce new programs or services, pending regulatory updates or general program guidance. The newsletters can be found on the same website that you see listed there. They're searchable by provider type and subject, and they are housed there in date order, so you're always able to go back. Again, they're very important to keep up on. The Medicaid Managed Care Contract. DMOS has a contract, as most of you are probably familiar with, the following Medicaid Managed Care organizations, which we call MCOs. Aetna Better Health of New Jersey, WellPoint, and WellPoint has recently had a name change. They were formerly AmeriGroup of New Jersey. You may be more familiar with that, but they're now known as WellPoint. Horizon NJ Health, United Healthcare Community Plan, and then finally Fidelis Care, who also had a name change relatively recently. They were formerly called WellCare Health Plans of New Jersey, and again, now known as Fidelis Care. I'm going to now turn it over to Melissa Brooks, who will speak on MCO specific requirements. Thank you.
Thank you, Linda. My name is Melissa Brooks. I'm the manager of Pharmacy Network Integrity for Horizon NJ Health. As part of today's presentation, I will discuss the topics here, which certainly align with Medicaid's traditional fee-for-service program guidelines, but just might be slightly more specific for each MCO's plan parameters and requirements. In this section, we will be covering provider portal, provider contracts, manuals, alerts, newsletters, and I will be providing contact information for each of the 5 New Jersey MCOs. I'm going to give you some general information as we go through, keeping in mind that each plan has their own resources and specific ways of doing things. So we will start with the provider portals. Each plan has sections of their website that are helpful for pharmacies when they need to know more about the Medicaid benefits that are available. So for instance, if you are working on a rejection and the prescribing physician is asking you to recommend a formulary alternative that is covered, sometimes the computer may give you a message within the reject itself, but you can also browse the formulary guides on the websites. Some prior authorization forms are available online, so if you want to help facilitate the prior auth process, you can fax the form to the physician to fill out. Also on the websites, there are policies which can provide additional information on covered services, requirements for certain drug therapies, contraindications, and so forth. And you can find phone numbers for the pharmacy help desks. They will be posted on a slide at the end of the presentation for your reference as well. Next slide, please. Some of you may be familiar with the process of getting contracted with a health plan, and as you would expect, there are various checkpoints and checklists that must be completed in order to do so. Usually there is a pre-screening process, which involves a virtual review of the pharmacy's New Jersey Board of Pharmacy license and the pharmacist in charge New Jersey license. And then there is a scan of various databases to make sure there are no sanctions for the licensees or exclusions from government programs, such as debarments, suspensions, etc. Next slide, please. So for provider contracts, we will move on to the paperwork packet, which typically includes the following information: the actual contract, copies of the required licenses, proof of insurance, the W-9 form, the EFT or the method of payment from the health plan to the pharmacy, and then maybe some other services also offered by the pharmacy, such as their hours of operation, and questions such as, do you offer prescription delivery, compounding, unit dose packaging for long-term cares, and things like that. Next slide, please. Moving on to the review phase. So we have collected the paperwork and now we have to verify it. And again, cross-reference it with various databases. If all of that checks out okay and the information is valid, we are ready to execute the contract. The pharmacy's information will be activated in the claims processing system, and the plan will then give the green light that it is okay to bill. Next slide, please. Once you are enrolled with the health plan's pharmacy network, there is continued monitoring and oversight of the pharmacy's credentials. We are required to perform regular checks of the pharmacy's licenses and the exclusion databases, which includes the CMS preclusion list, which essentially is a list of providers who are precluded from receiving payment for the Medicare Advantage services and Part D drugs prescribed to Medicare beneficiaries. And with regard to changes in the pharmacy's location or ownership, or in the event of a permanent closing, this will be covered in the next section. So more information to be presented on that. But I wanted to also mention it here because it is something that can potentially impact the patients and their access to their medications. Next slide, please. Some content on these items will be presented elsewhere in the presentation, but I wanted to just briefly mention the provider manuals in this section and to let you know that each plan may have their own information available in these manuals, which may include guidance on federal and state laws and regulations, record retention, documentation requirements, billing, and specifically claim submissions. A reminder to double check that the claim is accurate before submitted. Check the NDCs, prescribed quantity, day supply, etc. Collection of copays or cost sharing and third-party liability, commonly referred to as TPL, keeping in mind that Medicaid is the payer of last resort. Next slide, please. As for alerts and newsletters, please visit each plan's websites and also be on the lookout for notification the plans may send directly to the pharmacy, which could be in the form of a fax, email, phone call. And as Kay and Linda had mentioned earlier, the newsletters are available on njmmis.com. The contact information for each plan will be available toward the end of the presentation for the pharmacy help desk support, as well as for reporting suspicion of fraud, waste, or abuse. And now I will turn it over to Amanda Schreiber, who will touch on ownership and changes of ownership.
Thanks, Melissa. I'm going to kick off the area regarding red flags, and there's 4 potential red flag areas that we'll go over in this section. The first section I will talk about, which is ownership and change in ownership. The next section is on record keeping and invoice management. Another section on billing practices, and then finally a section on controlled drug substances and the New Jersey prescription monitoring program. As far as change in ownership, next slide, please. The Board of Pharmacy requires changes of ownership and asset acquisition notification. So within 30 days after the change, and that's the case for most changes, it's 30 days after the change, the new owner has to submit a permit application for change of ownership to the Board of Pharmacy. And then after that, the new owner also has to perform an inventory of the pharmacy's controlled substances. As far as changes of registered agents or officers of the organization, again, it's 30 days after the change that business entity must submit to the board an affidavit indicating those changes that have taken place. Again, more 30-day notifications. Other changes that have to be provided to the Board of Pharmacy include change of stock ownership that's greater than or equal to 10% of the outstanding stock of a publicly traded corporation. So again, that's an affidavit indicating the change that's taken place. And any reallocation of ownership interests amongst existing owners. So if one owner sells off their portion of ownership to the other remaining owners, that change also has to be submitted to the board by affidavit within 30 days after that change. So once there's a sale or a transfer of assets or ownership or all these changes we're talking about, the new owners will take custodial ownership of the previous 5 years of prescription and profile records of the pharmacy. So they're obtaining that information from the old owner and keeping that information on file. And then the new owner must ensure that all prescription and profile records are maintained pursuant to the Board of Pharmacy regulations after the date of acquisition. The board sends a letter to pharmacies to confirm these changes of ownership, and it now contains language to remind pharmacies of their obligation to notify the Medicaid program of these changes. That message is also available on the board's alert page, but it includes information on how to get in touch with the Medicaid program to tell them about changes in ownership. And with that, I think I'm sending it over to Linda Grajeda again.
Yes, thank you, Amanda. As Amanda stated, it's important to notify DMOS of changes in ownership. But first, as you see on the screenshot, in order to become a New Jersey Medicaid provider, ownership must be disclosed, specifically on the pharmacy provider enrollment application, disclosure of ownership, and control interest statement form. As you see on the screenshot there, if you go to the Medicaid website listed, you can click on provider enrollment application and then pick your provider type, pharmacy, in order to access the forms that you need. And then a note there, you can also select 21st Century Cures, which is a separate option on the drop-down list if 21st Century Cures is the enrollment type that you're interested in. As stated on the previous slide, page 13 of the pharmacy provider application defines ownership. And again, a reminder, it's required for both new applications and when changes of ownership occur. Regulation requires, and the regulation is noted there, regulation requires that you notify Medicaid, New Jersey Family Care of any change in ownership by submitting an updated ownership disclosure form from the pharmacy provider enrollment application we just looked at on the previous slide, and you submit that to Gainwell Technologies Provider Enrollment Unit, who is our vendor, to indicate a review process. Again, as a reminder, the pharmacy provider enrollment applications are on the Medicaid website, as is the 21st Century Cures application and disclosure of ownership document. If you have any questions, you can certainly reach out to Gainwell Technologies directly at the phone number listed or the email address provided. Any failure to notify change of ownership may result in action by the Medicaid program. This action could include monetary recovery, penalty assessment, and or prohibition of your participation as a Medicaid provider. So again, it's very important that you do in fact notify of changes in ownerships. I'm going to now turn it over to Kim Mateo, who's going to speak on record keeping and invoice management. Thank you.
Hello, good afternoon, everyone. My name is Kim Mateo, and I'm the supervisor within the SIU department here at Fidelis Care. I will be going over record keeping. There's two New Jersey statutes. The first one listed there indicates that providers shall agree to the examination and in making copies of any books and records that relate in any way to services rendered to any recipient and permit the inspection of the premises. The following New Jersey statute indicates providers shall agree that where such records do not document the extent of services billed, payment adjustments shall be necessary. Okay, records retention timelines. The New Jersey Statute Administrative Code that speaks to records retention timelines are listed below. MCO contracts indicates that records must be retained for the later of 10 years from the date of service or after the final payment is made under the provider's contract, subcontract, and all pending matters are closed. Timelines may vary depending upon the source. Follow the source with the greatest length of time that pertains to you. So record retention for this New Jersey Administrative Code requires the following information be maintained. Full name of the recipient to whom the service was rendered, date of service, nature and extent of service rendered, any additional information that may be required by the regulation, for example, Board of Pharmacy, DMOS, FDA, and DEA. Invoice management, record retention, MCO provider manuals. Pharmacies shall keep and maintain wholesaler, manufacturers, and distributor invoices and other purchase invoice and documents for prescription drugs and medical supplies for a minimum of 10 years. Records must indicate the following: price, drug name, dosage form, strength, NDC, lot number, and quantity. Pharmacies shall also maintain adequate records to validate purchases from wholesalers, which is proof of payment. Invoices and documentation must substantiate that the prescription drugs or medical supplies dispensed were purchased from an authorized source. National Association of Board of Pharmacy Accredited Drug Distributor, formerly known as BOD, licensed as a drug wholesale distributor in New Jersey. Adherence to additional track and trace requirements as mandated by the Drug Supply Chain Security will be in effect in November of 2024. Inventory transfers. In some cases, pharmacies may transfer inventory. The transfer of products, medical supplies from another licensed pharmacy must be verified and documented as originating from an NABP accredited drug distributor. All records involved in the transfer must be maintained and accessible for 10 years as well. Records retention for inventory transfers. So these records shall be contemporaneous with the transfer and shall include name of the prescription drug or medical supply, dosage form, strength, NDC, lot number, quantity, date transferred, the supplier's manufacturer's name, address, and registration number, as well as DSCS requirements if a transfer is not patient-specific. Best practices. So CMS Pharmacy Self-Auditing Tool. Pay attention to NDCs of medications that appear on wholesale invoice and receipts. Ensure wholesale distributors are reputable. Check NABP accredited drug distributor status. If no NABP accredited drug distributor status, ensure wholesalers are registered with the DEA and appropriate state controlled substance agencies. In New Jersey, agencies overseeing wholesalers is Department of Health, DOH. Do drug claims exceed purchases? If so, this is an invoice shortage. A shortage is considered a Medicaid overpayment. This may occur if there is not enough of a drug or if records do not exist for an NDC purchase. Maintain required product tracking information as required by DSCSA. Okay. I will now be turning this over to Tony, who will be covering Drug Supply Chain Security Act.
Thank you, Kim. Good afternoon, everybody. My name is Tony Key. I am a section supervisor with the Enforcement Bureau, Division of Consumer Affairs. Today, I will be presenting the topic of DSCSA. Please note that this presentation is only for educational purposes, and these slides do not represent the regulatory position that at the Division of Consumer Affairs, the Board of Pharmacy, or at the Enforcement Bureau. Next slide, please. So Kim touched upon the DSCSA. So what exactly is DSCSA? So the Drug Quality and Security Act, abbreviated as DQSA, was enacted by Congress on November 27, 2013. The DSCSA, Drug Supply Chain Security Act, is the Title II of the DQSA, which sets out a 10-year timeline to build an electronic interoperable system for the exchange of transaction documentations, which includes transaction information, transaction history, and the transaction statements, to enable the tracing of prescription medications serialized at both the case and the smallest unit of sale throughout the entire supply chain. Now, at the end of August 2023, the FDA announced a one-year so-called stabilization period. This particular period extends enforcement flexibility until November 27, 2024, give the supply chain partners the time they need to stabilize data exchange systems and processes developed to meet the final implementation requirements. The FDA has stated that it has intended for trading partners to keep working diligently and also recognize the supply chain readiness gaps and then wanted to ensure the products continue to move throughout the entire supply chain. Next slide, please. We're going to do a quick quiz to test yourself, your knowledge of the DSCSA. So we have 4 questions on the slide. The first one, is the Prescription Drug Marketing Act, the PDMA, pedigree provision still in effect? The second one, which drug do or do not fall under this DSCSA requirements? Number 3, who must comply with such a requirement? Number 4, when a pharmacy sells a product to another pharmacy, do the DSCSA product tracing requirements apply? Next slide, please. So for the question number 1, the answer is no. The pedigree provision of the Federal Food, Drug, and Cosmetic Act, FDC Act, which added by the PDMA of 1987, no longer exists, is no longer in effect. The DSCSA also added product tracing requirements in Section 582 of the FDC Act to provide and capture the transaction information, the transaction history, and the transaction statement, the so-called 3T data, associated with each transaction for most human prescription drugs in finished form. Next slide, please. Question number 2, which drug do or do not fall under the requirements of DSCSA? So we have to understand the definition first of a product. Product means a prescription drug in finished dosage form for administration to a patient without substantial further manufacturing, such as capsules, tablets, and a lyophilized product before reconstitution. The Section 582 requirements do not apply to following category items. Number 1, blood and blood components intended for transfusion, radioactive drugs or biological products, imaging drugs, certain IV drugs, medical gases, certain homeopathic drugs, and lawfully compounded drugs. So if your drug is not explicitly excluded by the law, DSCSA requirements will generally apply. DSCSA requirements do not apply to over-the-counter drugs or animal drugs. When items fitting to the definition of these products, then product tracing, product identifier, authorized trading partner, and verification requirements all apply. Okay, next slide. Question number 3. Who must comply with DSCSA requirements? The answer is drug manufacturers, repackagers, wholesale distributors, and dispensers, primarily pharmacies. So product tracing, product identifier, authorized trading partner, verification requirements in that Section 582 of the FDC Act apply to trading partners as defined in the Section 581.23a, which includes drug manufacturers, repackagers, wholesale distributors, and dispensers. So what happened to 3PL? So 3PL, even they do not take ownership of the products, but they take possession of the product, so they are still considered as trading partners. If an entity meets more than one trading partner definition, it must comply with all applicable requirements in Section 582 of the FDC Act, but it's not required to duplicate requirements. Next slide, please. Question number 4. When a pharmacy sells a product to another pharmacy, do the DSCSA product tracing requirements apply? The answer is yes, except for sales by a dispenser to another dispenser to fulfill a specific patient need. So the law defines a specific patient need as transferring a product from one pharmacy to another to fill a prescription drug for an identified patient. It does not include transferring a product from one pharmacy to another place to increase or replenish the stock in anticipation of a potential need. Next slide, please. It's just a recap of the key attributes of DSCSA. It really intends to protect the patients from drug products that are harmful and ineffective by tracking the product from the manufacturer to patient by protecting the product integrity. Establishes nationwide uniform and consistent standard for maintaining quality in prescription drug distribution. It requires prescription drug supply trading partners to build an electronic interoperable system to track and trace drug products throughout the entire supply chain. Enhances a trading partner's capability to identify and segregate a suspect and a legitimate product in supply chain. Now, know that regarding product acceptance, dispensers will no longer be permitted to accept the receipt of pharmaceutical products that do not have unique serial numbers. The law assumes that non-serialized products will be flushed through the supply chain. Next slide, please. So we are going to share some of the common schemes that we encounter in the marketplace. 5 categories. Number one, these are all case studies. Number one is a theft. This is referring to a case that related to a cancer specialty pharmacy inside a hospital system in Miami, Florida. A pharmacy technician stole over 3-year period of time and sold it to another individual worth over $14 million. The second one, we'll talk about counterfeit drugs. I know some of you got affected by Gilead Sciences HIV medications. On September 28, 2022, Gilead Sciences announced that they took new actions to halt an expensive criminal counterfeiting network responsible for selling illegitimate Gilead HIV medications. The third one we'll talk about is adulterated products. So in this particular case, on June 10, 2022, Lozano Hernandez, a resident of Miami-Dade County, Florida, and his affiliates have been charged by indictment with a conspiracy to introduce adulterated and misbranded drugs to default government-sponsored programs, conspiracy to traffic in pre-retail medication with false documentations, conspiracy to commit money laundering. Hernandez and his conspirators profit over $230 million from the scheme. Hernandez himself was sentenced to prison for 15 years. Number 4 and number 5, they're kind of interrelated. So we know that drugs are in shortage. We wanted to watch out very diligently when you purchase products from a gray market. Some of the stuff that we've seen that using closed door pharmacies or other non-for-profit pharmacies, such as hospitals and long-term care pharmacies, to engaging in unauthorized resale of products that manufacturers sell at a significant discount. We also see pharmacy purchase drug under disguise of own use for dispensing to their own patients. 3 is intra-company transfer from co-located or co-owned wholesale license to another pharmacy, or from a wholesaler make sale to another wholesaler or pharmacy. Next slide, please. So this is my last slide. When the price is too good to be true, we need to do due diligence. Every member of the supply chain has a responsibility to maintain drug traceability records. When we see the address on the invoice or packing slip, it says it's Suite 100, you got to do your due diligence. You want to make sure it's not just a simple mailbox. It has a physical address. So we all share a common objective, which is to promote public health interests. So with that, and that concludes my presentation for today. I'm now turning over to Mona, who will touch upon some of the red flags in billing practices.
Thank you, Tony. Hello, everyone. I am Mona Kriplani, Pharmacy Director with United Healthcare Community and State Plan. I have previously worked in this role as a billing and dispensing pharmacist for over 10 years, and I'm happy to review some of the responsible billing practices. Next slide, please. So to begin with, it is essential that pharmacies have the product in stock before submitting a claim. If a claim is submitted and the product is not in stock, the pharmacy should reverse the claim until the product comes back in and then resubmit. The claim submitted should essentially have the exact NDC or the National Drug Code of the product being dispensed down to the packet size. Please refer to New Jersey regulations, administrative codes, and the managed care provider manuals for additional information on this. Only and only the NDC of the actual product being dispensed shall be submitted on the claim. It is very important for New Jersey Family Care or Medicaid members because the state then applies for rebates, and we want to ensure that the state receives the appropriate rebate that they're entitled for. Continuing with refill practices, while auto refill is helpful to ensure member adherence, please ensure that you do not enroll members in auto refill or push bill without adequate patient consent or request, and do not enroll when prohibited. You can refer to the NJMMIS newsletter, volume 29, that outlines the New Jersey requirements. Use of any financial incentives to influence patients is prohibited. When a pharmacist uses the point of sale overrides, please ensure that the information provided for adjudication of a claim is accurate. Prior auth justification, if required, needs to come from the prescriber and must come from the prescriber and documented on the hard copy. For any MCO claims where the overrides are permitted, like a refill too soon, lock-in, DUR, etc., only use these point of sale overrides when the criteria is met. Next slide. When compounding, please keep and maintain the compound recipe worksheets with the identifying ingredients per the record keeping requirements mentioned earlier. Pharmacies must submit claims with all ingredients included in the compound and ensure that the NDC of the ingredients is the exact same NDC used for compounding. You can refer to the New Jersey regulations for additional guidance on compounding prescriptions. Also, the NJMMIS newsletter, volume 23, provides information on non-covered active pharmaceutical ingredients or APIs. For situations that a prescription is not picked up by a member, follow the New Jersey regulations and note that the Board of Pharmacy identifies a prescription medication to be abandoned when a prescription is prepared and made available for dispensing by the pharmacy, but is not dispensed to the patient for whom it was prepared for within 2 weeks. Pharmacies are required to initiate claim reversals for the point of sale payments for prescriptions not received by the members within 14 days of billing and filling. So just to summarize the best practices for billing, make sure that the quantities, days supply align with the claim submitted. The NDC dispensed must match the NDC on the claim. For compounded medications, bill the correct quantities used. Report any potential stockpiling or diversion activities. Always use the smallest available packaging and document when a larger packaging is used. If a Medicaid overpayment is identified, please self-disclose to the Medicaid Fraud Division. Follow proper billing procedures to return medications to stock and ensure that the billing for the claims is reversed. With that, I hand it over to Michael Alfano.
Hey, what's going on? I'm Mike Alfano from Aetna Better Health in New Jersey. We're going to talk about controlled substances and the New Jersey prescription monitoring program. So on controlled substances, these are going to be talked about by the DEA, the Drug Enforcement Agency, the Controlled Substances Act, the Drug Control Unit. There's a couple of hyperlinks embedded in the presentation here that speak about the controlled dangerous, what is a controlled dangerous substance, and chapter 45H, the controlled dangerous substance regulations. The New Jersey Prescription Monitoring Program, or the PMP, The New Jersey statutes are also embedded in this organization, in this presentation. And there's going to be the Chapter 45A, Subchapter 35 regulations also hyperlinked in. Next slide, please. Continued on controlled substances or best practices. We're going to ensure hiring procedures include adequate background checks on any employees that are dispensing these controlled substances. Ensure an accurate and ongoing inventory of the controlled substances within the pharmacy. Complete a physical inventory of all controlled substances every 2 years, which is a DEA requirement. Mitigate any physical security risks through access restrictions. Task the pharmacist in charge responsibilities should include complete a physical inventory for incoming and outgoing pharmacists in charge. Ensure the current licensure of the pharmacy and its personnel. Adhere to any registration requirements of the Controlled Substances Act. Comply with the New Jersey State Prescription Drug Monitoring Program, and comply with any Medicaid lock-in programs requirements. Next slide. Controlled substances on the New Jersey Prescription Monitoring Program. It is overseen by the New Jersey Division of Consumer Affairs, and it's established by the statutes listed there. The state database, it is a statewide database which collects prescription data on the following drugs and dispensed in outpatient settings in New Jersey and by out-of-state pharmacies dispensing into New Jersey. The 3 that are listed here are controlled dangerous substance, human growth hormone, and gabapentin. Next slide. Controlled substances, controlled drugs continued. Pharmacies are required to report information to the PMP on a daily basis. Prescription must be reported no more than 1 business day after the date the prescription was dispensed. The PMP does not collect any prescription records from inpatient facilities such as hospital, long-term care facilities, or any other where a patient is provided 24-hour care from a supervised healthcare professional. And the medication-assisted treatment and substance use disorder treatment facility information is currently protected under federal law and not shared with the PMP. Next slide. Controlled substances continued. Dangerous substances are registered prescribers, authorized prescriber delegates, and pharmacists who are licensed in the state of New Jersey and whose licenses are in good standing. New Jersey mental health practitioners providing treatment for substance abuse to patients at residential or outpatient facilities that are licensed by the Department of Health. The state and county medical examiners who certify that the request is for the purpose of investigating a death. Designated representatives of the state Medicaid program or any state board of healthcare professionals who certify they are engaged in a bona fide investigation. And federal, state, or municipal law enforcement officers acting pursuant to a grand jury subpoena or court order, and they're currently involved in an investigation. Next slide. The PMPM purpose is for healthcare professional program users to support clinical decisions, identify and minimize multiple prescriber pharmacy events and overprescribing, identify patients at risk for developing opioid use disorder, and state administration purposes are going to be to enable data-driven policy and collaboration, develop targeted interventions, and strengthen drug-related investigations with evidence-based intelligence. All right, I'm going to pass it over to Tracy Livingston, and he's going to talk about compliance and the MFD.
Hi, good afternoon, everyone. I'm here just to tell you a little bit about MFD and also about compliance. We're also going to give you a couple of best practices when you're putting together your compliance plan. And there's one thing to remember what we're talking about here with best practices each of you should have your own plan, but what we're trying to give you guys here is a little bit of best practices to make sure that you incorporate into your plan. But remember, everyone's plan is unique, but we want to give you certain elements that you should look at. First, you should ensure that claims submitted are for the actual NDC or the product dispense. I believe that was mentioned earlier. The quantity and days supply must reflect the prescriber's order. So you want to make sure that it matches the script. Maintain responsible billing practices. That kind of goes without saying. Just make sure that you document, and make sure that your documentation matches what you're billing out. Keep all prescription files and signature logs organized and complete. This is very, very important because even if you really have an internal audit, you want to be able to find that stuff. But if we also have to do an investigation or an audit, it'll be easy for you to get the information for us. Reverse payment and prescriptions not picked up. This is a real big one because obviously in the pharmacy world, this happens a lot. So you want to make sure that you have a good plan in place to deal with that, making sure that you're reversing those payments, reversing those payments, prescriptions not picked up. And also we wanted to mention to bill Medicaid as a payer of last resort. If you've been in the Medicaid world for a while, that pretty much means that if there's any other insurance out there, that you want to make sure that those insurances are exhausted before you build a Medicaid program. Thank you. Next slide. So a little bit about the Medicaid Fraud Division, or MFD for short. New Jersey Medicaid Program Integrity Protection Act established the Office of the Medicaid Inspector General to detect, prevent, and investigate Medicaid fraud and abuse and recover and properly expended Medicaid funds to enforce Medicaid rules and regulations. Audit cost reports and claims review of quality care given to Medicaid recipients. And I just want to just talk a little bit about that last part there about quality of care. That's something that a lot of people don't know about our office. They think we just do audits and investigations with, excuse me, with monetary recoveries. Excuse me, with monetary recoveries. We also do quality of care checks as well. So that's something that we also want to make sure that the services that are rendered to the Medicaid recipients, that they're getting adequate care and that they're also getting safe care. So that's something also that our office does, and I just wanted to point out. These functions, powers, and duties were later transferred to the Office of State Comptroller, or OSC, and are carried out by the Medicaid Fraud Division. The Medicaid Fraud Division performs program integrity functions, which is basically we're looking for fraud, waste, and abuse, which could come from an audit or an investigation, or you may also, sometimes we do desk reviews. So you'll see those as well. We conduct audits and investigations of potential fraud, waste, and abuse by providers and recipients. That's another thing also about our office. We're looking for FWA with providers and recipients. We coordinate program integrity oversight efforts among all state agencies that provide and administer Medicaid services and programs, which you can clearly tell from this presentation as we're working collectively together. The Medicaid Fraud Division also works to recover improperly expended Medicaid funds, enforces Medicaid rules and regulations, which goes into us working with all the agencies, including especially DMOS, audit cost reports and claims, review the quality of care given to Medicaid recipients. And I mentioned this earlier when I talked about quality of care. This is something that our office takes very, very seriously because it's not just a matter of paying claims correctly, but also the quality of care that is given to the Medicaid recipients. And we also exclude or terminate providers from the Medicaid program when necessary. This is another function of our office that is very, very important because what we found is most of our providers, you're in this business to make sure that you provide quality care to recipients. But sometimes when we have bad actors in the program, that actually brings down the program, not just for that provider, but for the program as a whole. So it's something that our office takes seriously. And when we actually come across a situation where it warrants to exclude or terminate a provider, we do that. Consequences. So this is one thing we also want to make really clear. So when we talk about things like your billing practices and your compliance program and stuff of that nature, you want to make sure that you have a good, robust program that can clearly show what your compliance program is and what your billing practices are and stuff of that nature. Because non-compliance with Medicaid rules, standards, and regulations regarding services may contact acts of fraud, waste, and abuse of Medicaid funds. And again, as I mentioned earlier, this is really what the main focus of the Office of State Comptroller Medicaid Fraud Division is here for. We're here to make sure that we're saving taxpayers' dollars and also looking out for the quality of care for Medicaid recipients. Okay, I'm now going to turn this over to Ryan Thillman, and thank you very much.
Thank you, Tracy. Good afternoon, everyone. My name is Ryan Thillman. I'm the senior investigator in the Special Investigation Unit with Fidelis Care, and I'll be talking about what is fraud, waste, and abuse. Fraud, an intentional deception or misrepresentation made by any person with the knowledge that the deception could result in some unauthorized benefit. Waste, generally understood to encompass overutilization or the misuse of resources, also not usually considered a criminal act, and lastly considered a legal violation for civil purposes and can result in a recovery of an overpayment, debarment from the Medicaid program and penalties. Abuse, provider practices that are inconsistent with proper sound fiscal business or professional or service delivery practices. Provider practices that result in unnecessary cost to improper payment by Medicaid or reimbursement for services that are not necessary, not approved, not documented, that are outside those specifically authorized. Waste and abuse professional due diligence. Business practices that result in waste and abuse can rise to the level of fraud, providing service without proper authorization unless it is emergent care, using unlicensed, unqualified, or untrained staff, inaccurate, incomplete documentation of service, billing for undocumented, unsubstantiated services, lastly, insufficient internal checks and balances. Civil Medicaid fraud, waste, and abuse consequences could result in civil judgments and liens, exclusion from the Medicaid, Medicare programs, referral for criminal prosecution, restitution recovery of overpayments, and additional penalties in addition to repaying Medicaid overpayments. I'm going to turn it over to Mary Crane, who will touch on audit and investigation findings. Thank you.
Thanks, Ryan. I'm an investigator lead at WellPoint, New Jersey, and I'm going to share a couple examples of some audit and investigation findings, like Ryan said. The first one is regarding Ozempic prescribing. And this isn't necessarily just one case. This is more of a project that we had been working on. And what we did was identify outlier prescribers who were identified for high volumes of the GLP-1 products. And as you know, I'm sure anyone who watches TV has seen the popularity that they have gained in recent years regarding the weight loss side effects or benefits of the GLP prescriptions. However, these drugs include Ozempic, Wegovy, and Saxenda, but only Wegovy and Saxenda are approved for weight loss at this time, but Ozempic is not. And what we found was a lot of prescribers prescribing Ozempic and basically for weight loss and not for type 2 diabetes. So what we did was request medical records to confirm the members had a diagnosis of diabetes and to substantiate the prescription. Next slide, please. And what we found was that some of the providers refused to respond to the records request. What we suspected and what was confirmed with some of the records was that they had charged the patient cash so they could prescribe for them because they knew that it would be denied if they sent the medical claim stating that they're being seen for weight loss and not necessarily diabetes. And then the records that were submitted had identified some of the members that were treated for weight loss, as I just stated, and did not have the diabetes diagnosis. So in these instances, the prior authorization for the prescription was improperly filled out and submitted, stating the member that had diabetes. So this would be an example of what was just shared as far as the examples of fraud, waste, and abuse. Next slide, please. We also did identify some providers that were associated with online telehealth weight loss clinics. Again, they advertised cash visits and helped with insurance prior authorizations. We also had providers come forward alleging that some of these groups had continued to use their NPI to write prescriptions without their knowledge or authorization after they had left that telehealth weight loss clinic. And then some of the authorizations that we found showed the member had a diagnosis of diabetes when they did not, meaning that they falsified the authorization to get it approved by the insurance. So some of our next steps with these providers is kind of an ongoing case-by-case basis. And what we are planning on doing is seeking recoveries from the prescribers when the PAs were falsified or altered in order to be approved. And that's been the main focus, with that, because if it's appropriately prescribed for a member with diabetes, then it's not an issue to be covered according to our policy. So next slide, please. Next thing I'm going to talk about is out-of-state licensure. And again, this is another project that we had implemented where we identified several pharmacies who are dispensing medications out of state. Some are registered as mail order pharmacies, but do not hold valid licensure in some of the states that they are mailing medications to. For example, Feel Good Pharmacy located in New Jersey. When I created this slide, I was not aware that it was an actual name of a pharmacy in New Jersey, but this is not affiliated with any real pharmacy. This is just for example purposes. So next slide, please. So let's say Dr. Diet is a telehealth provider located in Connecticut, writes a prescription for Ozempic and sends it to Feel Good Pharmacy. The member is actually in Florida, and Feel Good Pharmacy fills the prescription and mails it to the member in Florida. Feel Good Pharmacy is licensed in Jersey, and let's say they're also licensed in Connecticut, Georgia, Virginia, Alabama, and Kentucky. And again, this is just for example purposes. But if Feel Good Pharmacy does not hold a valid pharmacy licensure that's active in the remaining states across the US, then they should not be filling and mailing prescriptions to members out of state where they do not hold active licensure. I know, for example, New York, they do require out-of-state licensure if a prescriber or pharmacy sends anything to a member located in New York. But from my understanding with the Board of Pharmacy is that if any of those prescriptions total more than $500 in a calendar year, then they are required to have licensure to participate or fill prescriptions or mail them to that state. Next slide, please. And this, I think I'm turning this over.
Hi, thank you, Mary. Good afternoon. My name is Vera Jasker. I'm an investigator for the Medicaid Fraud Division. The first case I'm presenting is an inventory audit case, which I'm going to refer to as Anytown Pharmacy. So MFD opened Anytown Pharmacy based on a high volume of Medicaid claims, which included HIV medications, antipsychotics, opioids, and injectables. From that information, drugs were selected in order to have a more focused review. The completed inventory audit showed that Anytown Pharmacy had insufficient quantities of drugs in the pharmacy's inventory to support its Medicaid claims for these same drugs. Next page. Anytown Pharmacy was sent a notice of overpayment for the claims that were found to be discrepant in the inventory analysis. Then Anytown formally challenged MFD's investigative findings by requesting a contested case hearing in the Office of Administrative Law, OAL. MFD presented to the judge the legal and real-world significance of a pharmacy dispensing one product to a Medicaid recipient while submitting claims for payment to Medicaid for another product. Next page. After the first day of the OAL trial during which MFD presented its case, Anytown Pharmacy contacted MFD and agreed to settle the case. Anytown Pharmacy agreed to pay the Medicaid program the total amount of principal plus an additional payment of 6% interest. A settlement agreement was signed in which Anytown Pharmacy agreed to act in full compliance with all applicable state and federal rules and regulations, including but not limited to submitting only claims that accurately and completely reflect the services provided. Anytown Pharmacy specifically agreed that it would not bill Medicaid for a drug with one NDC number and dispense a drug with a different NDC number. Next page. Provider violations are listed below of the applicable statutes, regulations, and policies. They show that the pharmacy failed to have the necessary supporting documentation for claims which did not contain the national drug code of the actual drug dispensed. Next page. A second case that MFD opened, I'll refer to as Big City Pharmacy. This was a follow-up to a previous case for the same pharmacy in which an owner pharmacist had pleaded guilty to purchasing prescriptions, including HIV drugs, from indigent patients in order to bill for medications, but never dispense them. An inventory audit was conducted as a follow-up to the previous case. Next page. Despite the many signed testimonials by recipients of having received the medications in question, Big City Pharmacy was not able to provide the necessary documentation of having purchased all of these medications billed to the Medicaid program. A settlement agreement was signed and Big City Pharmacy agreed to repay the Medicaid program for all prescription claims which were not supported by wholesaler invoices. Big City Pharmacy also agreed to act in full compliance with all applicable state and federal laws and regulations and MCO policies, and agreed to only submit claims for services provided for which it possesses sufficient documentation to support such claims. Next page. The provided violations of the applicable statutes and regulations and MCO policies are listed below. They show that the pharmacy failed to have the necessary supporting documentation for claims for which it did not contain the national drug code of the actual drug dispense. I will now hand this off to Detective Michael Rosati from the Medicaid Fraud Control Unit.
Thank you, Vera. So my name is Michael Rosati. I am a detective with the Division of Criminal Justice, and I'm specifically assigned to the state's Medicaid Fraud Control Unit. We are part of the Attorney General's office, and we have statewide jurisdiction. There's a Medicaid Fraud Control Unit situated in each of the 50 states who receive Medicaid funding. So as highlighted throughout this presentation, Medicaid fraud is a serious crime. Medicaid fraud has the potential through dishonest providers to place immense financial strain on the Medicaid program, and their actions can compromise the program, its integrity, and also lead to patient harm. The Medicaid Fraud Control Unit, you'll see us sometimes abbreviated to the acronym MFCU or pronounced MFUCU, but we are the state's criminal oversight entity. We investigate and prosecute cases that involve Medicaid fraud, and we do that through attorneys. So we have deputy attorney generals who prosecute our cases. We also have detectives, so sworn criminal investigators, as well as civil investigators, nurse investigators, auditors, and other support staff who all work to help us police the Medicaid system. Okay, so our office investigates and prosecutes a wide variety of alleged criminal actions. So some of those can include allegations of physical abuse to beneficiaries, allegations involving healthcare providers who are suspected of defrauding the Medicaid program, fraudulent activities by providers against Medicaid, fraud within the administration of the program, and fraud against other federal or state-funded healthcare programs where there is a Medicaid nexus. Essentially, our office can investigate any case where there is a connection to Medicaid, the program, or a connection to Medicaid funds. So these are just some of the consequences that can come with engaging in Medicaid fraud. You can see at the top there, that's the specific statute for criminal healthcare claims fraud. It's illegal to submit a false claim to the Medicaid program or any insurance company in order to be paid for healthcare services which were not received or provided. As a second-degree offense, that can be punishable by a term of up to 10 years in state prison. In addition to all other criminal penalties allowed by law, a violator may be subject to a fine of up to 5 times the amount of any false claim. Additional consequences can include suspension or debarment from government-funded healthcare programs and forfeiture, suspension, or revocation of a professional license. Okay, so just some additional important things to remember. If you are a practitioner and hold a professional license, you only need to submit one false claim to be convicted. Willful ignorance of the truth or the falsity of a claim is not a defense, and you can be found guilty of healthcare claims fraud even if your claims were not intentionally fraudulent. Okay, these cases are publicized. So if you do engage in a Medicaid fraud scheme and it becomes the subject of one of our investigations, the matter will end up in the news. So this is a real life example of a case that was actually investigated and prosecuted by our office. But just for the purposes of this training and presentation, some of the identifying details have been removed. But so the headline here, Essex County pharmacist and his son were sentenced for defrauding Medicaid by more than $700,000. Okay, so essentially, as a case study for this particular matter, there was a pharmacy owner and their son who engaged in a cash for scripts fraud scheme. The large-scale multi-agency investigation that ensued involved the Medicaid Fraud Control Unit, so my office, as well as the FDA, Office of Criminal Investigations, and the local city police department where the pharmacy was located. As a result of the investigation, 13 defendants pleaded guilty for their roles in the scheme. That included the clinic owner, pharmacist, pharmacy technician, and multiple Medicaid beneficiaries who were involved in the scheme. So the pharmacy owner and their son both pleaded guilty to second-degree healthcare claims fraud. In addition, the son also pled guilty to third-degree witness tampering. The owner and the son each received a sentence of 3 years in state prison, and the owner had to surrender his pharmacy license. There was also an 8-year Medicaid exclusion applied to them, and restitution and civil penalties totaling $1.1 million had to be paid. So just to keep things simple, the bottom line is ignorance of the law excuses no one, and it is the provider's responsibility to know the laws that apply to their area of practice.
Thanks, Detective Rosati. This is Melanie Donnelly again. I'm going to touch on actions that MFD can take and talk a bit about ineligible providers, self-disclosures, and third-party liability. So the Medicaid Fraud Division has a number of recovery actions available in cases where Medicaid overpayments have been identified. This slide just gives a summary of those, and it includes notifying the provider of the estimated overpayment, filing a certificate of debt on property owned by the provider or business owner, including false claims penalties, and withholding future Medicaid payments until the overpayment is fully satisfied. So those are just some of the tools in the toolbox that MFD has available. This slide touches on ineligible providers. I know my colleague Tracy had previously mentioned this, but wanted to elaborate a little further. So providers who are debarred, disqualified, suspended, or excluded are deemed ineligible and not able to participate in federal or state-funded healthcare programs. And that means that those providers or the services furnished directly or indirectly by these individuals, ordered or prescribed by them, are not eligible for payment under these programs. And please be mindful of, for those of you who are employers, just remember that you must perform ineligible provider checks upon hire and then monthly thereafter of your staff members. That's incredibly important. This next slide does provide a host of provider resources that should be reviewed monthly and upon hire. I'm not going to go over all of them. They will be hyperlinked for you to access following the presentation, but I do want to bring your attention to the last item, number 7. So if the provider is an out-of-state provider, it's important that you must also check that state's exclusion or debarment list as well. Through the course of normal business, there might be times when providers uncover that they've been improperly paid. And when that happens, those issues must be disclosed and the overpayments must be returned within 60 days to the Medicaid program of identifying the issue. A self-disclosure form can be found on MFD's website. Again, the link here and will be accessible to you after the presentation. And providers who follow the self-disclosure protocols may avoid imposition of penalties. So this is extremely important. If you come across it, please report it. Third-party liability exists when an entity or party is or may be liable to pay all or a portion of the cost of medical assistance payable by the Medicaid program. Some examples of third-party liability are Medicare, commercial health insurance, and TRICARE. And as previously mentioned, Medicaid is deemed the payer of last resort. So all third-party liability, if it's available, should be used first and to the fullest extent to pay claims before Medicaid pays for the recipient. It's a violation of Section 1902A25D of the Federal Social Security Act to refuse to furnish cover services to any Medicaid beneficiary because of a third party's potential liability to pay for services. At the bottom of this slide are the hotlines, both in English and Spanish. If there are questions, you can reach out to those numbers. And we are going to wrap up. So we've reached the end of our presentation. We do want to share the contact information for the relevant state agencies and managed care organizations. These resources are available to you. Please do not hesitate to use them if you have questions. So this particular slide does contain the fee-for-service contacts. Next, we have the pharmacy help desk contacts for the managed care organizations. Again, don't furiously jot these down. The slides will be available after the presentation. And then these are the numbers for reporting fraud, waste, and abuse, along with links to reporting forms on the managed care organization websites, the Medicaid Fraud Control Unit, along with the Medicaid Fraud Division. And again, more ways to reach out to us if you have questions. I do see that some of you had been inputting questions into the Q&A. If after today you come upon something that you're seeking some information about, you could submit that question to this email address, providereducation@osc.nj.gov. We'll do your best to triage that question and get a response to you so that we can help point you in the right direction.